Hello, and thank you for joining us. My name is Jenny Pagel-Guile, and I am the Executive Director of the National Pancreas Foundation. The National Pancreas Foundation provides hope for those suffering from all forms of pancreatic disease. We fund research, advocate for better services and access to care, and provide support and education for patients and caregivers alike. We've awarded over 5 million grants as an organization, and we endorse over 180 centers of excellence across the country. We additionally provide programs, education to medical providers, patients, and their caregivers, providing a rounded scope of education and support to our community. There are many ways that you can be involved in the Pancreas Foundation, as well as several resources available online and on demand. We have the animated patient that provides detailed information about the diagnosis as well as the pancreas itself. We co-sponsor Camp Hope with Rebecca's Wish, our first pediatric pancreatitis camp in the country, and we provide nutrition support through our cookbook services and online webinars. All of this information can be found on our website, as well as a listing of all of our active centers of excellence. Across the country, we have over 30 chapters. These are volunteers and individuals who provide support to each other. They also provide grassroots efforts at tabling at local health fairs, providing fundraising support and education. They also sit in on advocacy calls at the local and national level. We would love to have you join us if you are able, or you can start a chapter in your community. Reach out to our staff if you would like to receive more information. Again, we have a full calendar of events, virtual and in person, on our website. We have an assortment of galas across the country. We have patient education events coming up in person, as well as medical professional events. And again, all of our webinars are available on demand online. The best way to stay up to date is to subscribe to our monthly newsletter. We also are on a variety of social media, so make sure that you follow us and share with your community and peers. We would love to have you join us. I would like to now introduce our speaker, Amir Zurakat. He is a professor of surgery at the Bernard F. Fisher Chair in Surgery at the University of Pittsburgh School of Medicine. He is the chief of the Division of Surgical Oncology, director of Surgical Oncology Services at UPMC Hillman's Cancer Center, and director of robotic surgery for the UPMC Health System. Dr. Zurakat specializes in cancers and diseases of the pancreas, stomach, liver, and duodenum, and is an expert in robotic pancreatic surgery. With over 300 publications, his academic interests include the multimodality treatment of pancreatic cancer and comparative effectiveness of open and robotic approaches to gastrointestinal cancers in general and pancreatic cancer in particular. Dr. Zurakat is a board certified in general surgery. He received his medical degree from the Royal College of Surgeons in Dublin, Ireland, completed general surgery residency at the University of Chicago, and his fellowship in surgical oncology at the University of Pittsburgh, UPMC. Dr. Zurakat is a member of the Society of University Surgeons, Society of Surgical Oncology, and the America's Hepatopancreobiliary Association. In addition, he is a fellow of the American College of Surgeons. Thank you for joining us today.
Good morning, everyone. This is Amir Zurakat, surgical oncology from the University of Pittsburgh. It's really a pleasure to give this webinar talk on advancements in minimally invasive pancreatic surgery. My title here says, "Are they worth the hype?" And hopefully we'll go through some of the data, whether it's UPMC data or national and international data, to answer that question. I'm very thankful for the National Pancreas Foundation for allowing me the opportunity to give this webinar. So without further ado, important with, I feel, with robotic surgery and any technology is the fact that many of us don't have any financial ties to Intuitive Surgical, so I don't have any disclosures when it comes to the surgical technology. At the University of Pittsburgh, we embraced robotic surgery early on, right around the 2008-2009 mark, and up until 2025. This is basically a summary of our pancreatic procedures up to date. Obviously, this talk is about minimally invasive pancreatic surgery, but I think all of us are interested in the Whipple operation, since this is the most taxing and most morbid of those operations. with a complex resection and reconstruction aspect of it. And to date, the University of Pittsburgh has done over 1,000 robotic Whipples. I also put some open Whipple data there, and open distal pancreatectomy and laparoscopic distal pancreatectomy data, just to show you all that selection is still important. We still do open Whipples, we still do open and laparoscopic distal pancreatectomies. But for the most part, approximately 60 to 70% of our Whipples are being done robotically, and nearly 90% of our distal pancreatectomies are being done robotically as well. But we've done a host of other operations, as can be seen here. We've published extensively on them, but for today's purposes, I'm going to focus on the Whipple. So why did we embrace robotic surgery? Why did we embrace the robotic Whipple as opposed to continuing with open surgery or adopting laparoscopic surgery? Well, we have had in the last decade or so some significant trials on laparoscopic versus open Whipple surgery. And you'll see here, these are 4 randomized controlled trials that are really international in nature. And really almost all of them indicate that the laparoscopic approach is associated with longer operative times. But in fact, 2 of the studies indicate that the laparoscopic Whipple may have a detrimental outcome compared to open surgery. Specifically, the Leopard 2 trial from the Netherlands was terminated early due to high 90-day mortality in the laparoscopic arm. And really, the better executed multi-center Chinese trial showed that although the laparoscopic approach was associated with a lower length of stay, and that was only by 1 day, the bile leak rate and the operative times were higher. When you see complications like bile leaks occurring more frequently with a new technique, it does indicate that either the learning curve has not been surpassed, or that the surgical technology may not be the adequate technology to handle complex operations or reconstructions like the Whipple. So 4 randomized trials indicating that the laparoscopic approach is at least equivalent, but maybe and more likely inferior to the open approach. And this was data that we felt was emerging throughout our experience at UPMC, and the robotic approach just is a better platform for the many reasons that many of you know about robotic surgery, whether it's 3D, dexterity, precision, and all of the other factors. And our belief in robotic surgery is really mirrored across the United States. This is an important paper that was published in 2022 on the U.S. trends in minimally invasive Whipple surgery for participants of NSQIP between 2014 and 2019. You'll see here that red applies to robotic Whipple, green to laparoscopic Whipple. And when you go through the years from 2014 to 2019, there is a tangible difference in the adoption of robotic Whipple. You'll see that the robotic approach is really increasing and really has surpassed laparoscopic surgery when it comes to this operation, whereas laparoscopic surgery has remained stable, if not slightly decreased in terms of performance. So surgeons are voting with their feet. The robotic approach is probably the more natural approach for surgeons when doing minimally invasive surgery. Obviously, the important point as well here is that these numbers are small. So in total, in 2019, approximately 10% of Whipples are being done minimally invasively, 90% are being done open. Again, it's a big operation, technically challenging, and a big learning curve. But the point to get across is that the robotic approach is increasing with surgeons voting with this platform over laparoscopic surgery. Well, it's not just the incidence, obviously. Why is that occurring? It's because the outcomes seem to be better with the robotic approach. This is a comparison from that same paper. The last year, 2018 to 2019, there were approximately 650 minimally invasive Whipples performed in the United States in NSQIP. The robotic approach was more common, as I mentioned previously. But take a look at some of these outcomes. The operative times are almost comparable. The transfusion rate is lower for the robotic approach, but mainly, as you all know, the conversion rate is lower, 15% versus 36%. So that's a big driver for surgeon adoption. Major morbidity is lower for the robotic approach. That's Clavy and Dindo, 3 or above. The clinically relevant postoperative pancreatic leak rate is lower, approaching statistical significance. And then this concept of an optimal outcome. Many of us do Whipple surgery, and I think there's a constellation of complications that can occur. And we have coined with others the definition of an optimal outcome, which is an absence of prolonged OR time, transfusion, serious complications, leak, the need for percutaneous drainage, a prolonged length of stay, readmission, or mortality. I think when we deal with a patient who has undergone a Whipple, it is all of these factors that encompass the post-operative care episode. And with robotic surgery, there is an increase in optimal outcome, and we see that across the years from 22% up to 35%, whereas laparoscopic surgery, again, has remained pretty stable in terms of optimal outcome occurring in about 25% of patients. Obviously, the bigger notion here is that we need to do better. We all feel it's unacceptable that only 35% of our patients goes through this operation without an issue. But again, the robotic approach is showing us that it is more possible to achieve an ideal outcome or an optimal outcome using this technology compared to laparoscopic surgery. So strong data, national data, this is not just UPMC data, national data that suggests that the robotic approach is associated with better outcomes. So we embraced robotic surgery for all of those factors. And this, I feel, is an important paper. Rather than rehash what we did in our early years, this is an analysis of our 500th robotic Whipple. This was done approximately 8 years ago. And you'll see here that some of these outcomes I would now classify as benchmark because they were based on almost a 7-year experience with robotic Whipples. Our OR time is approximately 6 hours. Blood loss is respectable. Transfusion rate is 4%. The conversion rate remains low at 5%. Approximately 15% of our cases are done with a vascular resection. The majority of these are a side bite of a vein. We've done full segmental resections, and I hope to show you a video shortly about that. The UPMC experience is important because approximately 50% of patients had pancreatic cancer. So we are selective, but to a degree, we are doing a fair number of cancers, which are really tougher resections, but easier reconstructions. The major morbidity rate at UPMC is 15%. The leak rate is low, and that's partly because we do a lot of pancreatic cancers and we have firm glands and large ducts. But that leak rate is under 5%. The length of stay is 6 days with a low 90-day mortality of 3%, a 30-day mortality of 1.5%. This was, again, an older paper published in 2018. So the R0 definition was then 0 millimeters at the margin, and that was 85%. With the new definition of a 1 millimeter or less margin, that goes down to approximately 60%. And then a respectable lymph node count of 34 lymph nodes on average per operation. So we published this at the 500 mark. We have data that's now being processed for the 1,000 robotic Whipples, and I can give you a sneak peek by telling you that the data is pretty similar. I feel we had achieved the learning curve when we went through the first 500 cases. The 1,000 cases have had some minor iterations in technique, but really the outcomes remain the same. And I would say that these are benchmark outcomes at the moment for minimally invasive robotic Whipples. Obviously, our experience stems from the fact that we collaborated and we had a group of surgeons that were working together early on. We were doing 2 attendings, and I'll go through some of the components of the learning curve. But the 1,000 cases that we've achieved so far are really thanks to a group of surgeons that include Herb Zay, Melissa Hogue, who left UPMC in 2018 but contributed significantly to the first 500 cases. Alessandro Paniccia, my partner currently, and myself are doing the robotic Whipples at the University of Pittsburgh. Obviously, this could not have been possible as well with the help of our fellows who were doing significant portions of the operation. Many of you will recognize these faces. In general, we have 5 surgical oncology fellows per year. Not everyone is interested in pancreatic surgery, but for those who are and are passionate about this and do want to start an HPV program or do robotic Whipples, this is achievable. and almost 85% of our cases were done with a surgeon and a fellow working together, and the fellow performing significant portions of the operation. And again, I put these pictures up because these are fellows that have now started robotic pancreatic programs at their institutions and are doing them successfully. So we're very happy and proud of this achievement. So I showed you single institutional benchmark numbers from the University of Pittsburgh. Well, how does this compare to open Whipples done elsewhere? This was a study that we performed, I feel a seminal study that we performed in conjunction with the Central Pancreas Consortium, which was a group of 6 high-volume U.S. Pancreatic centers. Was fortunate to collaborate with David Kuby on this. So we looked at over 1,000 Whipples performed at UPMC and Cleveland Clinic robotically. Those were 211 robotic cases, and then over 800 cases done by the 6 high-volume centers that represent the CPC. These were surgeons beyond the learning curve, and these were high-volume centers that were doing a significant number of Whipples per year. And the analysis, interestingly, showed that the robotic approach was associated with a reduced complication rate, an odds ratio of 0.64, or a 35% reduction in complications. This was statistically significant. The robotic approach was associated with longer operative times, and this is significant, over an hour longer. But again, I think you have to weigh the cost of a longer operation with the reduction in complications and length of stay and readmissions that comes with reduced complications. So overall, we felt that this was a favorable study and really a landmark study that shows that compared to open Whipple, robotic Whipples at high volume centers can achieve better outcomes. Obviously, this is retrospective. There's not been a prospective randomized trial for robotics in the US. Following up on this, obviously, you're all interested in the cost of robotics. And in general, for many operations, the costs are prohibitive sometimes. But if you achieve good outcomes, a reduction in complications translates to so many downstream effects. Then there may be a cost benefit to a robotic Whipple. And this is an important paper that we put out based on UPMC data alone. And the aim of this paper was to look at the synergy between minimally invasive surgery and ERAS, or enhanced recovery after surgery, which has been shown in minimally invasive colon surgery, laparoscopic colon surgery. And this data was very telling because prior to performing or instituting ERAS, the cost of an open Whipple at UPMC, and this includes everything in terms of the episode of care, including salaries and benefits and so forth, and amortization of the robots that we had used, that the cost of an open Whipple decreased non-statistically significant from $24,000 to $22,000 after instituting ERAS. But what we saw was really a replica of the colon experience, the colorectal experience in laparoscopic surgery. When you combined robotics with ERAS, then there was a significant reduction in cost, almost a $4,000 difference that was statistically significant. But I would look at the data in a bit of a different way. Looking at at open versus robotic, the robotic approach was associated with a significant reduction in complications at UPMC, such that the cost of a robot versus open Whipple before ERAS was instituted was quite similar. It was comparative, $24,000 each. But then you start looking at post-ERAS, the synergy between robotics and ERAS, and you'll see that although this is not statistically significant with a p-value of 0.135, you'll see that there's a reduction in the cost of a robotic Whipple done at UPMC compared to open. Again, some glimmers of hope that if you achieve the learning curve and you are able to do this operation well, that the cost is not really prohibitive. So how did we get to that state at UPMC? How do we get all of you to get a situation where you are running successful programs and performing a good, safe, technically sound, oncologically sound operation with outcomes that surpass open Whipple outcomes. For us, there are several considerations. The first I would label as programmatic considerations. You do need institutional support in the sense that we started our program with 2 attendings performing the first 80 robotic Whipples together. And the Whipple operation is a long operation, and having 2 attendings work together is really beneficial for a variety of reasons, but including limiting burnout, sharing ideas, sharing patient experiences, and really the partnership in the sense of building a program together. You do need guidance and mentorship, and now there's a variety of courses available throughout the country. UPMC has one through our Center of Advanced Robotic Training. Many others have this as well. This was really the brainchild of Melissa Hogue when she was at the University of Pittsburgh. She developed our curriculum for us. And this is from her publication. And many of you know Melissa's work and probably have seen this, but there's different components to the learning curve early on, and really it's mastery of the console, working on biotissue for haptic feedback, a video library. You need to look at a lot of prior experiences before jumping into a robotic Whipple. Obviously, there's an intra-operative part of it, which is coaching. This is something that's difficult to replicate, but you need to, I feel, go to a fellowship that does robotic Whipples routinely to be able to get that experience. And then finally, the ongoing QA, QI, and which cases to choose to do robotically. That's all part of the guidance and mentorship, which is available now at many, many institutions. And I would urge you all to really enroll in several of these. And if you're considering fellowships as well, just consider fellowships that are performing a large number of these robotic pancreatic surgeries, and fellowships who are beyond their learning curve. It's important that you manage expectations. These are long cases, and early on our learning curve showed that we were doing 10 and 12-hour operations. And that's not to say that won't happen to you. It's just as you and your administration and your chairs, your division chiefs know that is really part of the course is patience and perseverance, stepwise progression through these cases. And again, you need the guidance and mentorship to know the steps of these operations robotically, and setting time limits so that patients don't really get harmed by the initial learning curve experience. You don't want really unnecessarily prolonged operations. So it needs to be managed, and you can really get this sense from many of these courses. You do need high volume. 2 to 3 cases per month is what we had at UPMC. Doing 1 or 2 cases every 3 or 4 months is not going to get you over the learning curve. This needs to be a constant influx of cases, and you need to be doing these at least once or twice every couple of weeks to be able to get through the learning curve. So these are programmatic considerations. I feel as well, early adopters should look at patient considerations and anatomic, or what we say disease considerations. As you all know, it's important to perform preoperative imaging and avoid aberrant anomalous vessels. You can tell that by a triphasic CT scan. Avoid cases in which there's pancreatitis. Obviously, many of us are doing neoadjuvant therapy, and an EUS or ERCP with a stent can lead to pancreatitis. Avoid those cases, or wait as much as you can to do the operation, because pancreatitis causes this perivascular inflammation, and it's difficult to get on the vessels, and certainly this becomes a treacherous operation. Beware as you do an uncinate resection of the posterior first jejunal vein. I say this because in speaking to surgeons, and certainly some of the Dutch surgeons in the early Leopard 2 trial, this was an area in which surgeons can get into bleeding. And it's difficult to control minimally invasively unless you've gone through the learning curve already. It's difficult to avoid that first jejunal vein because you need to get the uncinate off. But sometimes if there's an anterior jejunal vein, then those are the best cases to do. But certainly just be aware. This is the benefit of having a senior surgeon in-house when you do these early on, or even having a senior partner with you in the operating room, because knowing the anatomy is really important. And here I don't want to digress too much, but the importance of learning the anatomy of an open Whipple is crucial. So I'm certainly a proponent of minimally invasive surgery, but I think the learning curve should be established in conjunction with open surgery as well. Knowing the anatomy is crucial. Other patient considerations are the pathology, the diagnosis. Obviously, there's a bit of an importance to avoiding borderline resectable pancreatic cancers. Reconstruction. Many of you are going to try doing these on IPMNs or duodenal cancers or PNETs. Those are easy resections, but the reconstructions are difficult because it's a soft gland, small bile duct, small pancreatic duct. So the leak rate can be high and will be high early on. The ideal case is a small pancreatic cancer with a double duct sign, or an ampullary cancer with a double duct sign in which there's no vascular abutment, but you've got large ducts to sew to. And again, those don't come frequently. So that's why pooling your surgeons together and achieving this partnership, this institutional partnership, to have surgeons working together to bring in those cases so that your case selection criteria is not too stringent and you're able to do 2 or 3 cases a month. Body habitus, obviously many of you know this, especially in males, the mesocolon can be very bulky and the mobilization is difficult. So I think an ideal BMI is 25 to 30. I would say beware of performing a robotic Whipple early on in a case with a bulky mesocolon. Also avoid cases who've had upper gastrointestinal reconstructions like gastrectomies or Billroth 2 or Roux-en-Y gastric bypasses. Early on, this is not advisable. You could certainly do these selectively later on. But try to do as straightforward a case as can be. For us at Pittsburgh, we need an experienced dynamic laparoscopic bedside assistant. I would submit to you that many of the reasons why we have these benchmark outcomes and respectable operative times is because you need a laparoscopic bedside assistant. I've seen others do these operations with minimal bedside assistance, and they can be long. To expand your selection criteria, keep the operative times at a respectable time, you do need a dynamic laparoscopic bedside assistant. This could be a chief resident, this could be a fellow, it could be a PA that is dynamic at the bedside, or it could be the surgeon, the attending surgeon at the bedside with the fellow at the console. But the UPMC way of doing this is really having an experienced bedside assistant that is able to retract sufficiently. And that really, we feel, brings down your operative time. These factors were actually really nicely recapitulated by Ugo Boggi in a paper published in Surgery in 2023. These are some of the hallmarks of a difficult robotic Whipple, and you'll see here high BMI, high ASA, an uncinate tumor, again, probably due to the abutment to the first jejunal vein or the SMA. It replaced hepatic artery off of the SMA. So that occurs in about 15, 18% of cases. Beware of those. Don't do those early on. A duct size that's small and a borderline resectable tumor. So many of the factors that I've just told you here were nicely put together in what's called the PD Robo score by Dr. Boggi. I do have a video here of where we are at UPMC with robotic Whipples. Obviously, this is a bit of a longer video and tells the story of an 82-year-old female with obstructive jaundice. On EUS, it was a T2N0 tumor. It was abutting the portal vein, as you can see here, with approximately 180 degrees. We gave neoadjuvant therapy, and the CA19-9 normalized. And we took her to the OR for a robotic Whipple. So this is transection of the GDA. We do this with a stapler. I've now routinely gone to tying it. We also clip it. As you all know from your training, you got to do 2 things for the GDA: tie, clip, staple, clip, or tie and suture ligature. This is identifying the SMV. We performed the tunnel along the splenic vein since the portal vein was involved. This is a Penrose being passed around the junction of the neck and the body. This is the portal vein above the level of the neck of the pancreas. And then here's the identification of the SMV below the neck of the pancreas. The key is to vessel loop, just like you do open surgery. Again, I emphasize the need for doing open surgery before you do all this. So this is the SMV being vessel looped. This is the portal vein being vessel looped as well, so achieving inflow, outflow control. Again, we only did these after performing 500 cases. And we've only done approximately 15 of these end-to-end anastomoses. We've done a lot of side bite resections, which are important cases in the learning curve. Here we're dividing the neck of or the junction of the neck and the body of the pancreas. The duct is divided sharply with the scissors. And now we proceed with resection of the uncinate. Again, the aim is to remove the uncinate as you do with open surgery. Remove it completely off of the SMA and leave it attached to the vein. That's the last move. So here we're approaching it from the right side, which is the traditional way of doing it. And now we flip the specimen. The specimen goes to the screen left, patient right. And now we're doing an artery first approach. So the SMA is to your right. And then the uncinate tissue is right there. Again, we're on the left side of the SMV, the left side of the portal vein. This is an important technical learning curve. You'll do this for open surgery and robotic surgery. So after we freed up the entire specimen, we take the middle colic vein with a stapler, we clamp the SMV, clamp the portal vein, and then we cut. This patient had neoadjuvant therapy. The CA19-9 normalized, so we feel a resection margin here is really determined by the neoadjuvant approach. And you're left with a bit of a gap, which we bring together with 6-O-proline in a primary anastomosis. Here's where the bedside assistant is crucial, because you have a big gap here, and you don't want the vein to tear. So you can see the bedside assistant here. This is really a 2 attending operation. Even till this day at UPMC, we do this with 2 attendings. And it's a running suture, just like you would do open. This is my partner, Dr. Panicia here. I'm at the bedside, and he's sewing the vein. So we've done nearly 100 vascular resections in total. Only 15 of them have been these end-to-end anastomoses, or the use of a patch, peritoneal patch or a pericardial patch. But we did not start doing these until we passed our 500th case. So that's really important to note. You have to go through the initial learning curve of first improving the outcomes for straightforward Whipples, and that takes a while. I'll show you some of that data here in a second. All right, we're going to stop here. The video does run and show a PJ and an HJ, but in the interest of time, I'll stop here. Here's just a quick recap of a pancreatic jejunectomy. I put these videos up because these are the cases that you are likely going to be doing early on: a soft pancreas and a small duct. This is a 1 millimeter duct that accepts a 4 French Hobbs stent. We use these routinely, not just to prevent leak, but to prevent to ease the actual technical part of the anastomosis. It's always good to see the whiteness of the stent as you sew the ductal mucosa, so that you don't occlude the duct. This is the modified Blumgart approach, and we really embrace this approach. And the modifications are several from the original Blumgart, but this is the top suture, kind of a horizontal mattress, full thickness. It's important to go beyond the capsule. I'd say about 1 to 2 centimeters, because you don't want to. The edge is always ischemic. You want to go beyond the edge, so to speak. This is the Pittsburgh modification of it, which is a stitch, the straddle stitch. You start above, and then you come through the bowel, and then you come up from below the stent. So above the stent and below the stent, it's important that you ensure the stent moves freely and the duct is not occluded. We feel that Pittsburgh modification to that stitch really prevents a posterior leak. And then we create an enterotomy. Important to keep the enterotomy small. There's, again, within all of these videos, there are minutiae of details. Every step has micro details, and these can only be achieved or attained through formal training. And again, these courses, these mentorship courses that are important, because each move has several sub moves to it, and it's important to gather all this to get these outcomes that you want when you apply minimally invasive surgery. So these are ductal mucosa sutures, and I'm going to stop here, but you'll see that these are the cases that you are going to be doing. So trying to minimize the leak rate early on is important. This is 5.0 PDS ductal mucosa suture. Why is this important? Well, for many of the outcomes that we see with Whipple, complication-wise, it is much of it is patient protoplasm, but I would submit to you that a lot of it is technical, and we saw these with those laparoscopic trials. Technique matters, and whether it's open surgery, laparoscopic surgery, or robotic surgery. Melissa Hogue did a beautiful study when she was at Pitt, looking at video review of pancreatic jejunostomies done with our modified Blumgart technique. And as you can tell from the video, there's the outer layer of sutures, but then there's the ductal mucosa layer, which is really, really important. And you'll see here, these videos were graded by 2 HPB surgeons. And certainly each one of those sutures, when it comes to placement or knot tying, is crucial in predicting leak. In fact, when Melissa did the multivariate analysis, this model of technical placement and tying of sutures was extremely important in predicting leak, in addition to the fistula risk score and other factors as well. But technique does matter. Leaks don't come out of a vacuum. Yes, there is protoplasm. Yes, there's many issues. The fistula risk score is very important, but it is technical at the end of the day. The learning curve is important to get you to sew properly, tie properly. And that comes from open surgery, but it also comes from dedicated training in robotic surgery. And it took us a while to realize this. We looked at our first 200 robotic Whipples, and the learning curve for us was long. And if you see this data here, this is our first 200 consecutive cases on a Q-sum analysis, a paper that Brian Boone published in 2013. And there's 3 phases to the UPMC learning curve. The initial big learning curve, which was really 80 cases, but then the learning curve continued until about 140 cases. And we have another paper that suggests that the learning curve went up to almost 240 cases. So it took us 20 cases to reduce blood loss conversion, almost 40 cases to bring down the CR-POP flavor, the pancreatic leak rate, to a respectable number, 40 cases. Again, think of the learning curve, think of how many cases you have to do to get over this. And that's why it's important to cut through the learning curve in your fellowship in a dedicated program. Operative time took us 80 minutes. But again, in terms of complications and length of stay, this will drag on to about 140, even longer. And this data has been corroborated by the Dutch pancreas group, who really, between Herb Zay, Melissa Hogue, and myself, we had the pleasure of going over to the Netherlands and proctoring some of their early cases in robotics after the Leopard 2 trial. And you'll see here that this paper by Mark Besselink shows pretty much what Pittsburgh's data shows, is that the learning curve initially is somewhere between 60 and 80 cases. Pretty similar numbers when it comes to other programs replicating the UPMC technique. This is a paper from China. Shows that initial learning curve was 100 cases. Again, we would call that the Dutch UPMC experience as well. For us, it was about 80 cases. But then the true learning curve, the mastery, the proficiency of it, in terms of reducing outcomes, can be up to 250 cases. Data that was also shown at UPMC as well. So keep that in mind as you're setting up programs, as you're thinking of doing robotic Whipples. You do need to be part of a program and a center that has a constant influx of cases. And this is not just for robotics, for open surgery. I think it's also similar. There's several papers that show that. So And I want to close by sharing with you some recent data. And this data is important for a variety of reasons, but there's been 3 randomized trials just published in the last year, or reported, sorry, in the last year, on robotic versus open Whipples, and these are really non-US based trials. This is the first one. This slide is provided to me by Mark Besselink on the Diploma 2 trial, which looked at open Whipples versus minimally invasive Whipples. And for here, the Dutch had abandoned the laparoscopic approach and were really doing robotic Whipples. 90% of the cases were robotic. And you'll see that the conversion rate for the robotic approach is 8%, which is very respectable. The complication index was similar. Time to functional recovery favored the robotic approach by 1 day. That's not a lot. Hospital length of stay was shorter by 2 days. I feel that that's significant. The leak rate was high in both open and robotic. You could argue that the Dutch still have a bit more in terms of working through the learning curve of the robotic approach, but certainly it was lower for the robotic approach compared to open surgery. Surgical site infection, I think we all know that from doing minimally invasive surgery, is going to be lower with the robotic approach. And mortality, again, this is at 90-day. It's still high. 4.6% is significant, but certainly not nothing that was too dangerous compared to the Leopard 2 trial, which was terminated early. So we felt that this was a good trial, a good start. If there's one criticism I would say is that we're running these trials a bit too early. Even this trial, which was based on a good learning curve, I feel still, based on the data that I showed you previously, it's just maybe too early to run some of these trials. Because some of the benchmark outcomes seen in the United States are better than what is being reported here in some of these trials. 2 other trials, really important for you to know, I feel, is the Chinese multi-center trial, which is a phase 3 randomized trial that was a superiority-based trial, run out of 3 centers, 14 surgeons, and the Europa trial run in Europe, which had a bit less stringent criteria for surgeon learning curve and case selection. This is very important because you'll see that the outcomes from these trials are quite different. I'm sorry about this busy slide. This will be the last slide that I have here. But the Chinese trial, if you focus on your left side, robotic 80 cases, open 80 cases, you'll see that some of the outcomes are very similar to what we reported at UPMC. Operative time was very respectable. It was actually shorter for the robotic approach compared to open. Blood loss is less. Conversion rate in the Chinese experience was 4%. And then the actual outcomes were very, very respectable. Lowish leak rate, low mortality. The length of stay was lower by 2 days. I would say this is a good, positive trial. And I would urge you to look at this publication, because the median number of cases that were done by center robotically was 200 cases, 200 Whipples, before they embarked on the trial. Each surgeon must have done 40 robotic Whipples and 60 open Whipples. And each center had a median of, I think, 214 cases before they embarked on this. So this was a trial that was truly, I feel, beyond the learning curve, and it's exemplified and shown in the data, as opposed to the Europa trial done by expert surgeons, but smaller trial, less stringent criteria in terms of the learning curve. And you'll see the operative times are longer for the robotic approach. Blood loss is high in both cases, robotic and open. A conversion rate that's 20%. That's a bit too high for surgeons if they are truly beyond their learning curve. Again, showing you the benchmark Pittsburgh data of 5% and the Chinese trial of about 4%. Major complication rates were higher for the robotic approach. The leak rate was higher for the robotic approach. Clearly, this trial indicates that these outcomes, to some extent, are not acceptable, and they are beyond the they're not beyond the learning curve, and they're truly within the learning curve. And not surprisingly, the cost of the robotic approach, either because of the technology or because of the complications, was really cost prohibitive, not cost effective here. So this is what it looks like if you're in the learning curve. So I think this trial was done preemptively too early, but also shows you that within the learning curve, unfortunately, some of the outcomes can be rough early on. So just keep that in mind. Keep the notion that I provided earlier about the learning curve and the rapidity of going through the learning curve. You need to go through 2 or 3 cases a month to be able to get through this learning curve quickly with your institution. So I'm going to close here, but hopefully I've shown you that the robotic approach really in the United States is showing a positive trend in terms of utilization. The national data shows us that the optimal outcome in the United States for robotics compared to laparoscopic Whipples is really favorable. There are a few series out there, whether it's the Chinese trial or the Pittsburgh data or some of the other high volume centers, the Carolina Medical Center, the Brian Boone and Carl Schmitz's experience at Virginia, Jin He's experience in Hopkins. When you look at pods of excellence and high volume institutions, the outcomes are better than they are for open surgery. We've not done a trial in the US. It's hard to perform a trial like that in the US. But with experience comes better outcomes. And you can see that in various publications across the US. A formalized training curriculum is important. I would say the courses are important. What you're doing with the National Pancreas Foundation is important. But enrolling through a fellowship, I think it is a must to be able to get these cases done. There's really no other alternative to intraoperative coaching other than going to a high volume center that has expert mentors that are beyond the learning curve. That is crucial. And I've shown you really a mixed bag of results here with OPD versus RPD trials in the last year. The important bit to note here is that some of these trials were done preemptively, prematurely, and the outcomes are not great. That should not dissuade us from doing robotic surgery. In fact, it should do the opposite. We should be adopting it with careful case selection and really trying to perform as many cases as possible to get over the learning curve before we start making comparisons to really an age-old operation, a good operation, which is the open Whipple. So with that, I'll close. Thank you so much for your attention. Please feel free to email me with any questions. And again, I thank the National Pancreas Foundation for giving me the opportunity to record this talk. Thank you very much.